Thank you so much. Okay, well, first of all, I'd like to thank again Professor He and also Professor Ao for allowing me this opportunity to share with you a topic. I was told I could talk on anything. I was told I could speak on any subject I like. So I'm going to talk to you on something slightly different just to wake you all up. Fake news in lung cancer surgery. So it's not what I usually speak on, but what I usually speak on is boring. I've been speaking on uniportal VATs, I've been speaking on non-intubated VATs, all this new technology for so many years now. And if you're not bored, I'm bored. So let's change it a little bit. And today I'm going to play the devil's advocate. And I'm going to show you that we as thoracic surgeons, although we like to boast about our achievements, there is something wrong with that. So let's get started. Fake news. I think these two words should not be strange to any of you. Everybody knows about fake news now, thanks to a certain American president. And you see fake news like this every day. You turn on your phone right now, this moment, take your phone, go on Google News, and you will find stuff like this. Complete garbage every single day. It's all fake. But fake news, there are many reasons why people put fake news out. Sometimes it's to manipulate people, to change the way you think. Sometimes it's for personal gain. Sometimes it's to influence policy, many, many reasons. But fake news comes about because of three special things. First of all, the people who contribute to create fake news, they are the people that have something to gain from it, because they probably come from a relatively economically compromised position. But they realize by putting fake news out, they have something to gain. And they don't have much to lose, because nowadays, nobody really goes and catches these people who create fake news. So they get away with it. But it's not just them. You can't blame them. You have to blame yourselves. The consumers of fake news are just the casual reader like you and me. We go on our internet, we read Facebook, we go on LinkedIn, whatever it is. We see some news, and we just think, interesting. We never question it. We don't objectively ask ourselves, is this believable? And part of it is convenience, because all this stuff coming through us on our smartphones is so readily digestible that, you read it casually, you digest it, you think it's real, and you just forget about it. And over time, that becomes reality for you. Now, there's also a third element, and these are the arbiters. The arbiters are the people like the press, the government, legal organizations, even industry, who traditionally monitor the news and make sure the news is reliable. But the advent of social media, things like Facebook, YouTube, WhatsApp, WeChat, whatever you like, all of these social medias are not subject to these arbitration processes. So all this kind of fake news, anybody can post on it, nobody censors it, it reaches the consumer directly, and there's no filtering. Everybody takes it in, and fake news propagates. And this has become, unfortunately, a trend for the world over the last few years. Now, there's another trend over the last few years, and that is the advent of thoracic surgery. Thoracic surgery over the last 5-10 years has boomed like crazy. We've had so many wonderful new innovations, things like robotic surgery. I was very lucky. I was the first person, the first thoracic surgeon to be certified in robotic surgery something like 12 years ago, and we brought it to Hong Kong. Never really took off for various reasons, but robotic surgery is being taken up in many parts of the world. Lots of people are doing it. They find it great. Instead, in Hong Kong, what I've been doing is we went down the uniportal route. So today, if you have lung cancer, early stage lung cancer, I can take it out for you through an incision just about 3 centimeters long, tiny, no rib spreading. We can do very complex surgery, anything from segmentectomies to sleeve lobectomies to pneumonectomies. We've done it all through just a tiny little wound. My patients, after a lung cancer resection nowadays, can go home in 2 days. I tell them, why don't you stay for a 3rd day? They said, no, I have no pain. I'm walking fine. I want to go home. So they're going home on the evening of the 2nd day, routinely. So this is another great piece of advance in thoracic surgery. We're not content with that. We're going on to things like non-intubated surgery. So nowadays, for my minor cases, for some of my sympathectomies, pneumothorax surgeries, we don't even intubate our patients when we do uniportal surgery. We leave them to breathe spontaneously while they're under very deep sedation or light GA. And with that, with the reduction of the intubation, they can eat within an hour of surgery. They can mobilize. They can even go home the same day. And for our work on this, we even won a prize in the European Society of Thoracic Surgery a couple of years ago. Another great achievement, so you can think. Don't show me that. Okay. Now, that's not the only thing. We've moved on to things like subxiphoid surgery. So this is another paper where I play devil's advocate saying, well, don't perform it. But actually, we've been doing subxiphoid surgery for some time now. Instead of going through the intercostal space, where we have the potential for damaging the intercostal nerve, we now go through the subcostal, subxiphoid approach, bypassing the intercostal nerve, and in theory, you get next to no pain at all. Fantastic. Of course, we've already heard earlier on about all these brand new technologies that will help to revolutionize how we localize these small screening detected lung lesions. In Shenzhen, we're introducing ValMap, virtual assisted lung mapping, to really use most advanced technology to localize completely impalpable lesions. Now, at this point, you're thinking, wow, there's so many advances in thoracic surgery. It's such a great time to be a lung cancer patient now. And to a certain point, it's true. It's great. We have a lot of new techniques and new technology. But have you asked yourselves, this is just me telling you how great I am. Is it too good to be true? And if it sounds too good to be true, that's because it probably is. And over the years, as I go around the world telling people about all these different technologies, there are people who say to me, hey, wait a minute, that's all fake news. You know, it's easy for me to put my videos on YouTube, on the internet, and tell you how great I am. But is there any evidence behind this? Now, that's the key thing. So, okay, I'm going to take the criticism seriously, and let's have a look at the evidence. Now, if we're looking at the evidence going from conventional VATS, which we've been doing for over 10, 15, 20 years now, and as we go on to uniportal VATS, we need the evidence to support that. Now, what kind of evidence? For that, we can look further back in history, when we went from open surgery to conventional VATS. And the evidence was built up very cleverly. Because today, three-port conventional VATS is no longer an alternative therapy. The guidelines say specifically it is preferred over thoracotomy for stage 1 lung cancer. It's not an alternative, it's preferred. Now, how did three-port VATS achieve this? It was invented in the early 1990s. And in the early days, we went through case reports, case series, really the lowest tier of evidence, the really cheapest kind of evidence. But that was enough to give you safety and feasibility. And through the 90s and early 21st century, we developed more and more increasingly better case control comparisons. So we're looking at not only crude benefits like pain and length of stay, all these cheap things, but we were looking at things like functional outcomes, inflammatory markers, and that established the advantage of minimally invasive surgery. And as we get on into the last 10, 15 years, we now have systematic reviews of big survival data analyses that prove the survival benefit of three-port VATS. That establishes conventional VATS. Now, using this standard, does this apply to uniportal VATS, this new stuff that we're advocating today? Let's have a look. So I actually just recently completed another systematic review. This is actually available online now. Now, just to cut a long story short, going through a single Ovid Medline database search for uniportal surgery for lung cancer, we find 314 papers. But after you filter them out, you'll find only 22 out of 314 papers actually provides any original clinical data supporting or talking about the use of uniportal VATS for lung cancer. Because most of those 314 papers were things like case reports, really cheap evidence, things like editorials, commentaries, letters to the editors, a lot of video articles or how I do it articles. And I have to confess that a lot of those papers I wrote. So I was contributing to garbage information. So I'm sorry about that. But anyway, let's have a look at these 22 papers. These 22 papers, most of them were just retrospective studies. Out of 22 papers, only 2 of them were actually prospective studies. Most of them were just case series, no comparison, just things to say that this can be done, it can be done safely. Very low-level evidence. And if you look at the comparative studies, only 13 comparative studies, the actual results showing any benefit over conventional VATS, it's very mixed. There are some papers that say it's good. Professor Mu actually contributed some of these papers, very good papers. But nonetheless, the evidence overall actually is not consistent. So although we're going around the world telling you how great this new surgery is, the consistency and the level of evidence is still very weak. So at this point, even though I'm a uniportal VATS surgeon, I have to confess to you that, yeah, maybe this is fake news. I don't know. But do you think that really matters? It doesn't. It doesn't matter to surgeons around the world, because despite the lack of evidence, people are flocking to me to learn uniportal VATS. Now, with Diego Gonzalez-Rivas and I in Shanghai, we've established a uniportal VATS training course. And over the last 4 or 5 years, we've trained over 350 thoracic surgeons from every continent on Earth, from Europe, from North America, from Africa, from South America, everywhere. They come, we've trained them. They love this approach, and they really, really want to come. Our waiting list for this training course is over a year long. But not only do they come to China, I go out to the world. I go around every single continent on Earth demonstrating surgery. We give talks on how to do uniportal VATS, wet labs, symposia. I've written the first textbook on uniportal VATS. And that's great for me. But is it good for medicine? Because I'm doing all this despite the fact that I know deep inside the evidence is still weak. And what worries me most of all is this. There is a corrosion of evidence-based medicine we're seeing here. In the past, everybody bases their practices, they worship evidence and good science. And what we're seeing in thoracic surgery today is this. The audience, the young surgeons, they don't listen to evidence anymore. They go to Facebook, they go to YouTube, and they see our videos out there. Wow, these fantastic uniportal videos. They see I can do it. They say, wow, if he can do it, I can do it. And for them, that's the standard of surgery. That's very, very worrying. Now, it's eroding things, and it's just because of those same 3 factors. Because people like me, the great villain, it's easy for me to put a video on the internet and say I'm the world's best surgeon. It's so easy, and I have nothing to lose, because none of you are going to actually get me for it. For the audience, it's fantastic, especially the younger surgeons. They're very impressionable. They see this kind of surgery and says, wow, Dr. SIHOE can do it better than my professor. This must be the greatest surgery in the world. I got to learn it. And if the young surgeons learn it, they see it as a way for them to leapfrog their seniors. I can do surgery my boss can't do. My hospital now can do surgery my boss couldn't do. And they see it as a great way to get a leg up. And that's one of their motivations for bypassing evidence. But there's another element, the arbiters, the people, the gatekeepers for evidence, they're failing because Facebook and YouTube are allowing them to bypass the traditional arbiters of evidence in medicine. Anybody can post on Facebook or YouTube. Now, what happens to those journals? These are the traditional arbiters. Now, to a certain extent, open access journals have actually corrupted the system. Because as we know, there are some open access journals that are fantastic, very, very high standard. But a lot of them, as you know, are predatory journals. And they accept any sort of garbage. You can post any video on any kind of crazy technique, and it will get accepted. And because it's open access, those hungry consumers can see it. And they're too lazy to think for themselves whether this is good evidence or not. Now, what about the traditional journals? The traditional peer-reviewed journals. Now, you might think that they're good arbiters, but I can tell you, as an editor of a couple of SCI journals myself, no, they're not. The journals themselves are a bit corrupt. The journals themselves, as everybody knows, they compete for impact factor, and that influences how they accept papers. They know, everybody knows this pyramid. They know that if I publish a good meta-analysis or systematic review, I will get citations. My impact factor will go up. So they're hungry and desperate for meta-analyses. And what we've seen over the last 5-10 years is that almost any meta-analyses will get published in a surgical journal. It's crazy. And a lot of authors are catching on to that. And what we found is that there are a lot of garbage meta-analyses. If you do garbage meta-analyses, you put garbage into your statistics, you're going to get garbage coming out, lousy conclusions. And we're seeing more and more of that being submitted to our journals. The editors, like myself, we're slowly catching on to this. And I have to take an example. One of the countries that produces more meta-analyses than anybody else is, unfortunately, our own country. And even Chinese editors, they publish this actually in the BMJ. They noticed that the standard of meta-analyses being submitted and published, in journals is not good at all. In fact, if you look at the quality of the papers being put into it, a lot of these meta-analyses don't even assess the quality. They don't actually look at comprehensive look over all the databases. They don't really give proper information about how they do their analyses or how they select papers. The quality is quite poor. And when we get poor quality meta-analyses, we get wrong conclusions. And it's not only that, it's not only meta-analyses, even the clinical studies being published are starting to become garbage. Now, everybody knows this paper, the Zhou Chang paper, in Lancet Oncology, no less. 3 years ago, this paper came out, and I cannot overemphasize how big an impact this had on the thoracic surgery community. Thoracic surgeons around the world were in shock. My God, surgery has become obsolete. But look carefully at that bottom part of this slide. Number at risk, 31 SABRE, 27 surgery. This paper, sorry to say, excuse my language, is a pile of garbage. There are so many problems with this paper. It's complete junk. In my opinion, it's not worth the paper it's published on. But nonetheless, it got published, and within the editorial circles, we know that the editors of Lancet Oncology published this because they knew this was controversial. It would get them citations, and this was one of their highest cited papers all year. They succeeded, but it really weakened medical evidence. Now, it weakened evidence because if you really look at the evidence, SBRT does not compare to surgery. When you're not looking at data from 30, 20 patients, when you're looking at databases with over 100,000 patients like this, or from the SEER database like this, or from the Veteran Administration database like this, thousands upon thousands of patients, surgery is consistently better. But this kind of data is boring. That Lancet Oncology paper was eye-catching. It was another example of fake news, but this time published in a major SCI journal, Lancet Oncology. So fake news has the power not only to promote crazy practices in surgery, but also to suppress good practices. Because surgeons were now in such an inferiority complex, they don't even dare talk about sublobar resection in a tumor board because there's a vague impression that SBRT might be better. Now, that's another negative effect. The final negative effect that I think is also very important that we have to talk about is fake news is a distraction. Now, last week, the Americans had their big election, and everybody who pays attention to news knew that one side of that election, they used fake news like scary migrant caravans to influence people. They influenced voters, where voters originally thought, they're on the right, that health care was a major election issue. By bringing all this fake news about the scary caravan, people's attention were diverted. They influenced voting patterns. Now, the problem with fake news in lung cancer is the same sort of thing. Because as a thoracic surgeon, I want you to just see this. I want you to think that my fantastic uniportal surgery will get this patient home happy and quickly without complications and no pain. And that's distracting you from the fact that there are many contributors to a patient's well-being, to how well they can recover, how well they survive their cancer. And by only focusing on one thing with the fake news, you're forgetting the fact that there are many other elements, things like ERAS, enhanced recovery after surgery. If we do a good perioperative nursing care, we actually improve patient recovery much better than any kind of fancy and minimally invasive surgery. I can reduce length of stay by 2 or 3 days simply by modifying how we do our nursing. Cheap and effective, but certainly not as sexy as minimally invasive surgery. We're reducing complication rates. Instead of buying fancy, expensive robots, we can buy something like this. Digital chest drainage, very cheap. And yet, just by using this, I'm reducing your length of stay by over a day. We're improving quality of life for patients. But this isn't sexy. It doesn't sell. We're forgetting very important things like screening. What's going to help patients, lung cancer patients, is not minimally invasive surgery. It's how we improve screening. And just a month or so ago, the Nelson trial, which in my opinion was one of the biggest pieces of news this year in lung cancer, Nelson shows that not only in America, but in Europe as well, lung cancer screening is making a difference. It's making a difference because this is astounding. Before screening, most patients were stage 3, stage 4. After screening, over 50% of patients with screening in Europe are now being diagnosed at stage 1. This is huge. And yet, in the last month or so, when I go to different conferences around Europe, nobody is talking about this, not in surgery circles. They're still talking about VATS and subxiphoid surgery. That's distraction. They're distracting from very important advances like this. Many studies are now going on looking at immunotherapy for early stage lung cancer and trying to combine it with surgery. But again, a graph like this is boring when I could show you one of my surgical videos and you'd be mesmerized. So that's all distraction. So just to wrap everything up, fake news in lung cancer surgery, I think it's very popular for both the creators of the fake news and the consumers. It undermines evidence-based medicine. Unfortunately, it's bypassing control by traditional arbiters, the traditional journals and everybody. It can promote bad practices and suppress good practices like good sublobar surgery. And it distracts clinicians from more important considerations in lung cancer. Now, at this point, you'll be thinking, this is a thoracic surgeon speaking. It's got nothing to do with me. I'm an oncologist. But sorry, we're all in the same boat together. If one part of lung cancer management fails, we all drown. And if evidence-based medicine gets compromised, we all get compromised. So we do have to pay attention. Thankfully, there are many ways to spot fake news. Very simply, you need to understand who's creating the fake news. People like me, who have something to gain from it. Always question the motivation. You also have to question the source, the media you're reading it from. Are you reading it from a peer-reviewed journal or from social media, my Facebook posts, which I post all the time? Okay, I'm culprit. But even when I publish in the mainstream journals, sometimes the journals themselves are not necessarily doing their gatekeeping job. And last but not least, you need to check your own biases. It's not just my fault. It's your fault for listening to the garbage I spew out because it sounds fancy. A lot of people like looking at these nice videos, these nice fancy surgery. But we need to question ourselves. Are we looking at the evidence or just looking at the video? And it's very important because as we go into the next 5, 10 years, there are so many other wonderful advances in thoracic surgery out there. And unless we learn to spot fake news, all of these things we're not going to look at very objectively, and that will be to the detriment of patients. So thank you very much.